name's John Lenz. I'm a SIM office policy analyst. So my main job task is really working with the policy, how things are working, a little bit behind the scenes. This is super exciting work though, and so the goal is to give an overview of things. I was told numerous times that this is an informal gathering, so if anybody has any questions, please let me know. Somebody said something about a microphone earlier too. Can everybody hear me? Yeah. Okay. Perfect. Yeah. So SIM is the state innovation model, and so a lot of people who are working in innovation, like in IT innovation and like entrepreneurial innovators, a lot of times will say things like, what's your innovation? What's your disruptor model? How are you guys like really like breaking the mold and really going forward, like the bleeding edge of technology? We're federally funded. We're a federal grant through the state, and we're working on rising the whole tide of Colorado. And so a lot of what we're talking about, some people will say like, how is this innovation? But we're really setting the environment in order for healthcare to transform as we're moving forward. All right, so if things are seeming like they're not like this bleeding edge of innovation, that's what it's here. So the goal is to improve the health of Coloradans by providing access to integrated physical and behavioral healthcare services and coordinated systems with value-based payment structures for 80% of Colorado residents by 2019. Technically, our federal funding stops January 1st, 2019. So we want to try to integrate care between physical health and behavioral health with alternative payment model structures for 80%, have at least 80% of Coloradans have access to that by January 1st, 2019. The major way that we're doing this is we are not just a standalone office. We're trying to collaborate with as many stakeholders as possible throughout the state. And we are working as the hub for all of these stakeholders to get together. We do report out to the Centers for Medicare and Medicaid Innovation, CMMI. That is who our funding is through, actually. So we do report out to them directly, and we are one of many SIM programs throughout the nation. But the way that we are organized is we are working with these different work groups, and these are all specific work groups. The public health work group was mentioned earlier. We also have payer reform work group, and we also have conversations directly with payers to try to work on these alternative payment models. Primary care providers, we work through practice transformation, as well as the health systems, behavioral health providers, and we have a consumers work group, consumer engagement work group. We really do work with as many people all together as possible to try to make sure that it's not just one entity or one interest that's coming together with it. We're also working closely with the TCPI model. This is more of a practice transformation. Did I understand correctly? You guys are more on a public health lens. Is there anybody here on like a practice level of like primary care physician? Okay, so modify it towards public health lens, yeah? Certainly. So TCPI is very exciting and innovative. It's working on practice transformation. This is how it's doing. This is the SIM approach. So in order for 80% of Coloradans to have integrated care, we're working on 4 main pillars, which is payment reform, practice transformation, population health, and HIT. Let's talk about the other 3 quick and then talk about population health. Payment reform is working from going with this episodic model of care. I want one thing done, I will pay for one thing, right? To working towards population-based payment structures. It's really interesting ways in which to do that, but it first needs to be linked to value and then move forward from that. We are in conversations with private insurers and public insurers in order to move these conversations forward. Practice transformation is mainly through the University of Colorado. They're our main vendor working with individual practices. We have cohorts of practices that are involved, and we are working directly with them and working on changing not just how they're interacting with their behavioral health and physical health, but also how their business models are set up to be able to work in this new population-based arena. HIT is the health information technology. This is the backbone, a lot of infrastructure stuff. I'm seeing some eyes glaze over. It is very important. It is how a lot of things work behind the scenes, and so we're working on how to make sure that this works well going forward. Oh, yeah? Okay. Sweet. All right. Then, if anybody is interested in the HIT work group, and we're always looking for public at large, and feel free to contact us as well. Population health. This is one of the value adds, the really big value adds of the SIM program. We are not only working on transforming how healthcare is delivered, but also integrating in population health into the healthcare of Colorado. And so we are working on a lot of nebulous things that aren't necessarily easily addressed, and we're able to start looking at social determinants of health and working with giving that information back to providers through all of our systems in order to be able to work on the larger picture aspect. So, and that's just the overview. Yeah?
So how does this model define access?
Excellent question. So the main thing is having it at all available first, right? And then it works into ease of access, right? But Colorado is a very wide state with a lot of differing levels of practice capabilities, and so it's hard to say exactly what it is a statewide program, but making sure that it is available at all, and then being able to increase the ability to get to it. Yeah. Practice transformation. We're working with primary care practices as well as bidirectional health homes. This is actually really fascinating because most of the time when we think of care, we think of our family doctor, our primary care physician, right? These are the PCPs. Bidirectional health homes is actually starting from people who are, their main practitioner is mental health services, behavioral health services, right? And then from there, integrating or providing access to the primary care physician practice, right? And so this is kind of flipping it around a little bit because the care should be integrated, needs to be integrated, but rather than just saying we're going to start with the PCPs and then move toward trying to get access to behavioral health, starting with behavioral health, and then ensuring that their care is coordinated from that starting point. The ramp up of the beginning 2015, this is when things started, and this was planning stages, getting stakeholders involved, making sure that people kind of had a good idea where we could go all together. 2016 was when our first cohort was introduced. We have initial 100 practices coming on. At the end, we're going to have 400 practices with direct contributions from SIM, direct support from SIM, in order to get the whole system moving forward towards our goal of 80% of Coloradans having access.
Yeah. So can I ask if it goes in the rural and urban areas?
Oh, yeah.
It's a mixture, right?
Yeah. Statewide. Yep. Excellent question. So we're at the end of 2016. Cohort 1 has already been established. Cohort 2 is going to be coming in February. We'll be accepting applications for that, and then
is everybody accepted, or?
Well, so we need to make sure that people are gonna be able to be supported well, and so they're evaluated on the strength of the practice and ability of the practice to be able to work with these programs. So in order to move them towards integrated care, we need to make sure that they have the capacity and support.
So again, who is the board, or who is, that do the evaluation?
The SIM office, the SIM office and University of Colorado. Yep. Yep.
Thinking more about the role, how do you integrate primary care? Is that like medicine? Is that,
That's a great way.
practices, or as all practices that patient understanding is there's not enough as all providers?
Yeah. So, and one of our main work groups that we're also doing as well is workforce development. And so we're working on trying to develop the workforce as the SIM office. We're bringing in people to have these conversations in a concerted way in order to be able to move this conversation forward. It is kind of nebulous. It's a hard question to answer. And so being able to bring in the interested people into one space is one of the main advantages of SIM. And so we are a hub of all of these stakeholders to be able to bring things together. Yeah, so it's workforce development, telehealth, certainly, there's great promise with that, but it's also an emerging industry. And so being able to understand what telehealth actually is, instead of just saying like telehealth, right, and then go for it, right? We're having a lot of conversations about how to move telehealth forward, and then also how to integrate telehealth practitioners with primary care providers to be able to make sure that it is actually access and not just the illusion of it. Yeah.
And then are you also, I think I saw that you involved in, are you
Yeah.
working with providers and payers to help them with health insurance?
Yes. Yeah, so a lot of, this might be a little bit, yeah. So a lot of the ways in which mental health providers are paid is through a per member per month carve-out through payment models, which is good because it's a progressive way of paying for population care, but it then also can limit the ways in which care is provided. And so we're also working with Healthcare Policy and Finance, Health First Colorado, Colorado Medicaid, to be able to work with fee-for-service type models with links to quality, and being able to work with these with the providers in more direct ways, and then be able to move everybody working together. Did I answer that? I feel like I was,
Yeah.
okay.
Curious about how, like, without the how integration.
Absolutely. Yeah.
I can tell you what happened to Denver Health.
Yeah.
Hi,
you?
The Denver Health has a behavioral health specialist as part of the care team within the clinic. And so I'm seeing a patient and they're depressed and they're having a crisis. I can have their behavioral specialist do that with either a social worker, like a social worker, or a psychologist that will see them. They'll see a note, they'll see, and they can then follow them. If they need to get into a mental health center, they can help expedite that. They can also work with our behavioral, like our psychiatrist, if they need to get medicine. I might, just to say something else, they can, or they can go to the hospital. So it works really well in that sense. It's a nice warm handoff, or we set up an appointment and they'll do it. And so it's for anything that's sort of like a related. So it's a great model, and we built for both primary care and for the behavioral health system. And the state can do that out. Joint billing on the same day.
Very cool. And some behavioral health and physical health practices are not co-located. And so working on the warm handoff and all of these things are definitely conversations that we have been having with multiple stakeholders, how to make sure that these interests are being addressed throughout these practices. Excellent question. Keep the questions coming. The characteristics of the current practices, there's CPC practices is comprehensive, it's the federal grant, collaborative primary care? Comprehensive primary care. All right, CPC, we always just say CPC, sorry. I want to say comprehensive primary care practices. So these practices are also participating in another federally funded program in order to be able to integrate care and be able to provide care at an advanced level. So this is through CMMI. This is a directly federally funded program, and it shows that a third of our practices are these innovators, these people who are really working on making sure that they're innovating within healthcare and their healthcare delivery models. School-based health centers, residency programs, FQHCs or lookalikes, 20, and because there's 100 practices, these are literally percentages as well. The average Medicaid percentage is the population within the practices, and average Medicare is 14%. I know, yeah. It's fine. Bidirectional health homes that we were talking about earlier, there are the 4 that were identified around the state of Colorado, and these we are working directly with to make sure that their integration with primary care is directly supported.
Comprehensive primary care.
Comprehensive primary care. Thank you so much. And this is the federal funding. It is because it's the CPC programs are on a federal lens. They're necessarily a little bit more broad and less involved than the SIM program. We're a Colorado-specific program, and we have more direct support within the state. This is our academic foundation. These are Bodenheimer's building blocks, starting from the bottom, working at the clinical level, working with these different ways to be able to start integrating care and working towards a full integrative, whole person care is the top block. That guy. Sorry, I think they were earlier. The getting up to full integration is a great aspirational goal. A lot of practices feel that they are really far along the way towards integration, but when you start breaking it out as to what are the steps, what are the blocks that we need to ensure are in place before we can say, yes, we have full integration, this is our academic model for this. This is Bodenheimer's blocks, working from cooperation to coordination to integration. And these conceptual blocks are actually easy to break out with clinical quality measures, with practice transformation measures, thresholds for payers to be able to work with and see how things are moving forward. It helps us operationalize this work towards integrated care. The payer MOU, Memorandum of Understanding. This might be a little bit dry for some people not interested in statement reform, but it's very, very important. In order to support the practice transformation, there is infrastructure changes that do need to be supported financially. So this is the enhanced financial support when practices are proving that they're doing this work. They need more administrative support. They need more different things. They're investing in being able to work at these integrated levels. Then the payers are agreeing to enhance their financial support for that work. Data sharing is also a very important thing. The payers are actually sharing their claims data now with the state of Colorado. And this is actually quite innovative, that being able to use what the claims are and seeing behind the scenes under the hood of what is actually happening with the claims at the practice level is huge. And it's these various payers on the right-hand side have all signed this MOU, and there's a press release link there as well. Aligning the quality measures is huge. It would seem like it wouldn't be that big of a deal, but if you have 7 different payers that all have different quality measures that would like to see different things from different practices, how they're moving forward, it doesn't really work so well, because if you only have 3% of your population is being paid out by Kaiser, you're not going to change your entire organization to be able to meet those requirements. So by aligning quality measures, there's more value for every practice moving forward. And then the common approach to accountability as well is agreeing where those accountability measures are going to be put into place. So might seem dry, super important, really exciting work. And also this is unique to Colorado. We're the only state that's moved this as far forward as we have. Yes?
How long does it take to develop that strategy?
It
sounds like it's very comprehensive.
In
order to get all the payers on board.
I want to say that the initial conversation started in 2010. The specifics have been in the works since 2014, and now we're really moving forward in really tangible ways. We're really setting up the quality measures that payers are agreeing to now. So beginning of calendar year 2017, we're going to have very specific goals that payers are agreeing to. And this is absolutely unique in Colorado. Yeah.
You might have talked about this when I was gone together, but didn't we apply for STEM and then not get it? We got a get ready grant, and then we applied again, got it?
Yep.
So that's why this conversation is evolved so much.
So within the ecosystem, STEM is one program that's it's an innovation program, and it's only a 4-year program to be able to push it as far forward as possible within that set time, and then STEM dissolves. Right. So the first grant was a preparedness grant to see what might be able to happen in Colorado, and then from that, this is where the operational plan came out and all this.
Preparedness, not public health preparedness, but prepared for STEM.
For STEM, sorry, yes.
Mm-hmm. Preparedness means a different word when you're here.
Fair enough. Thank you for the level setting. I appreciate it. Yeah. Yes. Yeah, excellent questions. HIT strategy. So again, these are within these 4 big pillars with payer, HIT, population health, and practice transformation. So HIT strategy is expanding telehealth, right? Really big. Broadband internet capability. The shared practice learning improvement tool is actually referred to as SPLIT, and it's all capital letters. This is actually a tool that was developed with STEM and the University of Colorado in order to be able to be a centralized reporting system for practices that are interested in moving their care forward and integrating their care, rather than having 40 different reporting outs. We're trying to bring it all into one to simplify the burden on practices, because there's a ton of reporting that's really being done here. And if we can simplify and put it all into one easy, convenient location, this is something that will be able to live past the life of STEM as well and be a long-term benefit to the state. Integrating existing system components with aggregate data, and then creating reporting capabilities for user health information, and including but not limited to population health. Right, so this is part of the SPLIT tool, as well as working with different stakeholders to be able to see where the data aggregation is going to be able to support these different initiatives going forward. Payer support, we've been talking about that a bit already. There's been existing commitments by payers. Everybody's interested in figuring out how to achieve the triple aim, right? Better care, better access, less money, right? Everybody's been interested in this for a long time. And so there's been existing models, and so continuing models with parts that work and those commitments that work, and then improving on them as well. So continuation, extension, modification, and support within your practice, then the payer support or the payer initiative, having that payer support is really not that important to you. So there are 13 practices with only one payer impaneled with them, working with them on SIM initiatives, willing to pay more for doing this integrated care, right? But then it goes up to 5 payers, right, with for 12 of the practices involved, right? So this is just a breakout of the different levels of support. Practice facilitators, you were asking about practice facilitators earlier. Practice facilitators work within the practice transformation organizations, or PTOs, if you hear that in state conversations. The practice facilitators are the people who are working directly with the practices and their functions. So they're the ones who are working on change and QI, quality improvement, making sure that behavioral health integration is going forward. Yeah, these are the people that are working with the business structure itself. And the CHEETAs, which is my favorite acronym within state efforts here, is the clinical HIT, health information technology, support people. And these are the people who are working on the HIT capabilities for each practice. So when we support each practice, we give them access to practice facilitators, PS, and CHEETAs, the clinical health integration, health information technology. Oops. Regional health connectors. This is awesome. The regional health connectors are resources that are being rolled out throughout Colorado. Actually, I think there's a map of where. No? Okay. Well, it'll come up later, I think. The blue ones within this model are what SIM is directly supporting. We are using SIM monies to directly support the practice transformation organizations, which is the PFs and the CHEETAs, and then also the regional health connectors. And the regional health connectors are a resource for different regions around Colorado in order to be able to connect everything that's going on, from public health to school lunch programs to community behavioral health clinics, to all of the different, anything involving healthcare, public health, everything all together, all with one single resource hub to be able to maximize the impact that everybody has. Yeah, it's great. It's great work, and it's interesting, and this is actually work that's being influenced by the population health work group through SIM, which is meeting on Monday. Practice improvement plans. This is from those Bodenheimer building blocks, the block pyramid. What are practices within cohort 1 working on right now? The dark green is practice transformation goals, the medium green is behavioral health, and then the light is health information technology. So obviously data-driven improvement is a big HIT goal, and almost everybody within cohort 1 is working on it, right? So it's pretty easy to see. But it's good to also map out that within cohort 1, most people within cohort 1 want to work on population management with the lens of behavioral health goals, right? So this is good data. We are getting a lot of good data from cohort 1 because we've had them in our system for a good while. And we're starting to get the data back, and it's going to become a much more data-rich environment as we go forward. Stories from the field. I feel like we want to be a little bit more public health oriented. We'll keep going. This is the population health. These are the counties that are directly contracted to SIM, have SIM practices, have the direct communication with the SIM office and the SIM work groups. But the RHCs are throughout all of Colorado. Yeah?
You guys have a model where organizations can collaborate with each other instead of going through the SIM model. Is that space you provided, or is it more going
Yeah.
through you guys? Okay.
Oh, yeah. So SIM is also, is a 4-year grant, right? We're not building ourselves to be around for 50 years and everything else. We want to create the environment for success for everybody who comes into SIM and is involved with SIM. We're trying to work ourselves out of a job, right? So while we're bringing people together, we're also trying to create these links that will have long-term success. Certainly. Yeah, thanks. So this is a big one for this group. How are practices tracking population health in SIM empanelment? This is the amount of people who are working with their own health, working with their behavioral health, working with being a part of the care team, really being involved, not just having access, but being involved with their care. Risk stratification, social determinants of health, where is the risk, how are things working out? We're doing this through data aggregation and report outs from the practices, et cetera. Care management, working on setting up these systems for care integration, even with not directly co-located services, making sure that there is this access and ability to be able to do these. ECQMs are just clinical quality measures transmitted electronically. Using the data in quality improvement. Shared decision-making aids. This is giving the power to the people, making sure that people are able to work with what's going on with their own healthcare, with their own communities, data, making sure that it's not just held on to by SIM. And then embedding the use of evidence-based guidelines. We're really big into evidence-based practice, of course, and everything comes back to an academic model or data-driven model. Everything has a solid foundation.
Can you describe more about how you use that risk stratification? Because I think of it in different ways.
Sure.
What do you mean by risk stratification?
I believe that the best way is just to say that we're working on it. It's not a, different people are coming to it with different lenses. And so the biggest thing is being able to have the data for what we want to be able to work with the different risk levels or what is.
Just like tiering population?
We're building the baselines to be able to do that, right? Or whatever needs to be stratified for risk. But this is on a population health level, not on an insurance risk level.
No, I understand that.
Right.
But I'm thinking about like people who have had multiple admissions to a hospital would be risk stratified higher, say for psychotic breakdowns or whatever, things like that.
Right.
Versus somebody who has had one episode of clinical depression or something like that. Is that the risk stratification you're talking about? Or are you talking about like somebody being lower socioeconomic status and that kind of thing? So that's what I'm asking,
Right.
What you mean by risk stratification.
So aspirationally, we would love to get to that level.
Which one?
The like pure social determinants of health, being able to use all of the data, all coming all through together as a state, right? But practically speaking, we're not really there yet. And so we can only use the data that we have access to. And so we're trying to build up the data model that we are using, but this is still with your first example of
So it's
where
more
our
about care and utilization.
yeah, and the integration thereof of the care. Yeah. Yeah, thank you. Excellent question. I wish I had a more, like, we're doing this big style yet, but we're.
Well, I think that's a.
Yes, you gotta start something. Yeah.
I'm not sure if it's directly related, but I was just thinking that, you know, what the next experience community is.
Right.
Here in Denver. And there was some talk about working with different DHEs and clinics to do a better job of coordinating care for high-risk users.
Yeah.
So that could be.
Yep, and it's definitely Yeah, all of it fits within the coordination of care and the overall mission of SIM. So we're, I mean, yeah, there's a lot of different things all working together. Oh, sorry. Rates of reported CQMs. This is the data that we're getting back. So speaking of what data we're using and how we're actually operationalizing this, we are getting data back already from the first cohort, from these practices working directly with us, reporting back information at very high levels, right? Which is, it doesn't seem like it's all at 100% reporting back, but in order to get people on board, we started out by asking, please report back 1 or 2 measures so that we can start this work. We want to start building capacity for reporting out, right? So getting at the lowest measure, 34.4%, this is pretty great. We are getting a lot of interest. A lot of people are coming back and they are really getting involved. And we're moving forward. This data is becoming more robust as we're moving forward, not only with more CQMs, clinical quality measures, but also with the amount of people that are reporting back quality data. Yeah.
Do you have baseline data on how many facilities were reporting this information before it's been out, or is it? Or is that right there for you? I know it's baseline data is like this.
No, it's a great question, but it doesn't actually, the way in which we're asking for this information is fairly unique. And so we could look at practices that were involved in other programs that are also involved in SIM and find that. But that hashing out is not super right. So it's kind of a new way of thinking about reporting out, and we're building up this cohort and asking them to do things that they actually haven't done in this specific way. Yeah, we could do retroactive, like looking if they have been tracking these sorts of things, but it's time and money, you know. Yeah, cheers. Sorry, no, okay. So this is from the self-reported question of it's the iPad, which is Integrated Practices Assessment Tracking Assessment Tool. And so we asked practices, where on these building blocks, where along this path towards full integration, where are you? And there goes from if you remember those levels, the coordinated care, co-located, and then integrated. The first level is minimal collaboration. These would be like a rural clinic with one service provided, and they're just trying to get by and provide basic level services, but they don't have really any idea how they would connect with integrated care or to behavioral health care as well, all the way to level 6, which is fully collaborated in a transformed and merged integrated practice. What normally happens when there's these self-assessments that go out, and it's through a series of questions. It's not just like rate yourself 1 to 6, right? But when people look at all of these questions and say, oh yeah, no, we provide this, right, before they've started, normally the reporting is towards the high end, and then they start doing the work with practice transformation and integrating their care, and it actually moves back a bit, and then it starts going back up because people start to realize what exactly is entailed in this work. So it's actually really encouraging that there's a whole spread, and it's encouraging that people are towards the top levels because it's not just saying this is where people can serve, but this is also where people are aspiring to. This is where people really want to go towards this more integrated level. This is our baseline level. This is the first time that practices in Colorado have been asked this specific question with this tool. So we'll be interested to see where this goes from here. This is the behavioral health questions that are being addressed right now within integrated practices. The PHQ-2 and PHQ-9 is basic depression screenings that any primary care physician practitioner can do, and this is the effort screen, brief intervention, the third? Yeah, I'm getting a positive nod, yes. Bam, got it. So within this model, this is how we, this is a way that practices can show integrated care at this time. It is a toehold. It's not fully integrated care, right? But it's a good place to start. And so this is where we're asking people to report out. And this leads towards understanding of population, coordinating care with specialists, and embedding a behavioral health specialist as well is also being worked out, practical ways in which to do that. People are starting to talk a little bit more. Within the primary care practices, these are the main ways in which we're really interacting. These are the direct supports that we are going to practices and saying, this is how we are supporting them. Direct payment for the innovators. Practices are eligible to receive up to $5,000 in participation payments. Grants to practices, if people hire on a staff member or invest in new technology or whatever else, there are specific grants possible for specific practices up to $40,000. Alternative payment models, this is kind of nebulous. It's really hard for a lot of people to understand. How can you get paid on a population base when you're seeing patients every day, right? And so supporting that transition towards APM is really, really important. And so we're spending a lot of time on this as well. Practice facilitators and cheetahs are being done through our practice transformation organizations. I believe there's 22 of them throughout the state of Colorado. Might be 21, I think it's 22. So it's customizable, whatever practices are interested, how they're interested in working with people to help them out. There's a wide array of them. Business consultation. We are working with a couple of different contractors to work with the business models involved in providing integrated care. It's a great thing to say that we want to be able to do this, but being able to have the nuts and bolts capability to be able to provide it is really important, and we are providing that direct business consultation and support to the practices involved in STEM. And then finally, with the regional health connectors, each STEM practice is directly matched with the regional health connector. Everybody throughout the state of Colorado has access to regional health connectors, but we're actually taking the extra step to say, make sure that you're interacting with your RHC to make sure that the care integration is able to move forward even more. This is how practices are using the small grant funds, and this is the up to $40,000 amount. Yep, you guys have questions on this? Not as many of note here, not as many of them are being used for capital costs, right? So this would be improvements like we need a new entrance lobby, right? A facility cost, buy more computers cost, some sort of like physical thing. Most of it's working on how practice is delivered, how healthcare is really rolled out.
What are some ways to use that?
So getting a compliant EHR is actually a big thing. We as consumers have a natural tendency to assume that people just have the right backbones and have the tools to be able to provide care. We're getting close to full adoption of EHRs in Colorado, but not everybody is fully using electronic health records. So this is just getting up to not just a basic Excel spreadsheet, but an actual EHR that's compliant and able to communicate with outside organizations. This is huge. There's a lot of real costs associated with that. Excellent question. Oh, sorry. Any other questions on that? Training, patient engagement, EHR modifications, ability to implement, experts. Some of the EHRs have no capacity to be able to integrate any behavioral health, anything within them. So modifying the EHRs to be able to do this. Capital cost, behavioral health specialist time. These are all very practical ways in which these grants are being used. Practice transformation, again, this is at the practice organization level. How is QI structured? And how is that being engaged with? And then what are the barriers and how are things actually moving forward? I do want to make sure that there's time for just open questions at the end, so I'm going to speed up a little bit. This is a fairly packed slide deck. Practice community culture. Here we go. And these are more opportunities for engagement. This is really big. You guys are going to have access to the slides, right? Yes, okay. So this is if you're interested in any of these work groups, clicking on this will give an overview of what the work groups are and how to engage with them. The SIM website as well also has links to the work groups. You can call in and listen and see what's going on, or also read the minutes from past ones. Or if you have questions, feel free to contact me or anybody on the SIM team, and we can certainly answer questions. But the public meetings and work groups are a very essential part of what SIM does, because we're not a standalone organization. We do want to work ourselves out of a job, and we want to do it as collaborative of a way as possible that builds as much use as possible to the state of Colorado. Also, primary care practices, please join the second and third cohorts of SIM participating practices. If you guys know practices out and around Colorado, please encourage them to join in. There's requests for applications. It's going out in February, and we're very interested in continuing the conversation. And here's some information. I thought for some reason I needed to speed up. This is last slide. You guys have any questions? Yeah.
First of all, thanks to a lot of people, including people who are working in this thing. Then has also felt very much like pieces of the puzzle scattered all over the table, and they don't have the box cover.
Sure.
I appreciate the presentation with the box cover.
Yeah.
Two questions. The first, given your 30,000 foot view,
Yeah.
can you tell us how things are going with all the different moving parts?
Yeah.
Can you speak to any potential implications around, say, 4 years, or could that change given the uncertainty around the APS?
Sure. So, 30,000 foot view. Yes. Great. So the 30,000 foot view is really still within the state of Colorado, the big view. We have a ton of work, right? And this is actually great that everybody at the SIM office and all of the stakeholders, nobody's really complacent. We're all kind of hungry for the next step and how to move things forward. There's a really good sense of urgency within the SIM office. We really want to keep moving things forward, and there's a lot of hunger for success. Defining success, moving tangibly forward towards it. This is definitely happening. The 130,000 foot view, the really big, looking at the whole nation, we're light years ahead of everybody else. And so this is actually really important to keep communicating out to groups of stakeholders, is that while we are still hungry and we have a sense of urgency, we're doing some things that we don't have good frameworks for because nobody else is doing it. People talk about talking to a multi-payer collaborative, right? Leaders are Maine and I think New Jersey, and there's been a couple of attempts in California, but nobody's actually getting all the payers at one table to talk, right? And so we're we're not only supporting practices individually, we're not only working with population health, we're not only working with payers, we're actually doing this in a very collaborative way that's really unprecedented. And so, like, the really, really big view is like thumbs up, we're doing great. So like looking at it as like within the STEM office is we gotta go. We're really excited to keep moving. What does the political future show? Quite honestly, governments are set up, or our United States government is set up as a bureaucracy. There's an inherent stability in moving slow with some things. Funding for STEM specifically is through CMMI, which was mandated through the Affordable Care Act. Nothing for certain, but there's a lot of things in play to slow down rash decisions. Look at that, all political. Yeah. Feel all right about that one. I think my boss is going to listen to this one later too, so. Yeah, and it's a great question though, yeah, but there's, yeah, so things are good, we're excited to keep moving forward, and there's precedent for it not washing away.
How many applications do you expect to see?
For cohort 2?
Yes.
We talked about this a lot back and forth, if we should try to accept more and try to make the final cohort smaller, but we're shooting for 150 practices in cohort 2. If the numbers are around where the interest is for CPC, the federal program, would probably be around 200, 250 applications. And so we'll be looking to really make sure that we're getting the right practices involved that can really benefit and really help move this forward. But we still need to, get the word out, so let people know if you know people.
Yeah, I was curious if you're get a lot more than you need, or you have to actually
There's been a lot of interest, actually, and so because it's kind of, it is innovative, it is moving forward at in kind of the space of uncomfort for a lot of practices. So not a lot of people would seemingly be interested in it. And then also, like, there was the first cohort, so like, what can you prove from the first cohort? What's the actual support? And the responses have actually been very encouraging. So people are one, very excited to have been part of SIM, and then also looking forward to being a part of SIM. Yeah. 3 minutes still. Anybody have any questions about SIM? All right. Our information is here. Nicole came. This is actually Nicole's presentation. She is the expert. Heather Grimshaw is our communications person. She's got access to all the fancy infographics. If you're interested in any cool stuff about SIM, she's the one to talk to there. And then I'm John. Paul? No, not Paul. Not Paul. Sure. Thank you so much for your guys' time. Thank you.